Hi, welcome to KiwaniTalk. We're a public information program put together by people from the Dearborn Kiwanis Club, help from students at Dearborn High School, my alma mater. Welcome to the longest running cable access show in the entire world. My name is Gary Gardner, and today we're going to talk about physical therapy, something that people of my vintage are more and more concerned about, but people who all ranges from young children to geriatrics like myself need to have attention paid to it. And to talk with us about that today, we have Dr. Jeff Garbacz from Advanced Physical Therapy here in Dearborn, all over Metro Detroit area. Doc, welcome to the show.
Thank you. Thank you for having me.
It's great to have you here. No, the physical therapy thing is something that you don't know you need it till you need it sometimes.
Yeah.
And you didn't know you needed it until you got into it. Where did you go to school? How did you get into physical therapy?
Yeah, so I really made the decision to become a physical therapist my sophomore year of college, undergrad at Albion College, kind of deciding to go either between athletic training or physical therapy, and really decided after some research as to what each profession kind of brought in regards to lifestyle to go down the PT route. And I was fortunate enough to have good enough grades and academic success to get into grad school right after my bachelor's degree from Albion, and then went on to physical therapy school at the University of Michigan Flint. So,
okay, and so physical therapy is something that probably has been around for a while, but it's become more and more of a practiced or recognized field since when? How long has it been more recognized?
Yeah, so it's been around a long time. Started as a nursing profession, I believe, in World War I, and it's kind of evolved, profoundly since that time. And but with the aging population and people always sustaining injuries, not just athletically, but just wear and tear type of problems that they have, there's always a need, right? And so the profession is strong from a job perspective, and people looking for a good career. There's opportunities that are currently available and will be probably forever based on that.
Is there a difference between chiropractic and physical therapy, or are they kind of different branches of the same thing? What's the differential? Because people don't really understand either of them.
Yeah, there is some overlap in what each profession can provide. There is some differences as well. I think the biggest difference for us as physical therapists is we can do some of the manual interventions that a chiropractor can do, but we're also very apt in providing exercise-based treatments, which is not always done in a chiropractic office. And so, as a PT, I'm a little biased, but I think our approach is a little bit more comprehensive across the board regarding that.
So to become a physical therapist, you're a doc, but do you have to be a doctor to be a physical therapist?
Yeah, so funny story about myself. I graduated from physical therapy school in 2002. It was December, so I always lose track of the year, but to graduate in December 2002, and I was actually part of the first class in the state of Michigan to get the doctorate level degree. Now all educational programs throughout the country are at that level. So yes, to be a physical therapist, you will graduate from an accredited program with a doctorate in physical therapy degree, and it's a clinical doctorate. So it's not a PhD like someone who does research. It's not a medical doctor like a medical doctor would be. It's very parallel to a doctor of chiropractic medicine or a doctor of optometry or a doctor of podiatry. It's very much similar to that.
So you can't prescribe much besides exercise.
Correct. Yeah, exactly. We can't write any prescriptions, but we can provide treatments in regards to what people can do to help their ailments, for sure.
So at the intro, I mentioned you have a range of infants to geriatrics to centenarians.
Yeah.
Then talk about how a baby would be involved with the physical therapy situation and what could be done. Why would they be there, and what can you do for them?
Yeah, so pediatric therapy is a niche market within our profession for sure, much like other niche markets are in the world of PT. So physical therapists can help infants or children with birth defects, cerebral palsy, any type of physical disability that they may have from birth. We can help with restoring motion and gaining strength and helping them walk more efficiently, things like that. So let's talk
about the cerebral palsy thing. So people have heard about that. I'm not real familiar with it. What would a pediatric patient with cerebral palsy, what would they present as? How would they come in, and how would you hope that they could leave?
Yeah, so I'm not an expert in pediatric therapy.
Okay, but
However,
you're
I know
exposed to it,
enough
yeah.
about it, right?
Okay.
So there's certain milestones in development that occur, and when those things don't happen, physical therapists can help. For instance, rolling, right? Like a child rolls from side to side, or crawling or creeping activities. And we can help facilitate motion at certain joints or strengthening in certain muscles to allow those movements to happen. And then it just helps the development of the child at that point.
So they have trouble doing the more basic type of stuff, and then they're. How about as you get from the pediatrics to more like the 7, 8, 10-year-olds? They're still pediatric, but what kind of patients do you see in that age range?
Yeah, so at that point, I mean, you're getting into more of the active population, perhaps the orthopedic world, where kids are becoming more active in running, jumping, playing sports, things like that. Those are really the types of patients we see at our clinics. And we treat patients as young as 5 or 6, all the way up through high school and college. So varying levels of varying types of injuries, really just depends on that patient's situation.
So how would a parent for a child of that age, how would they make the decision to come to a physical therapist? Either something's wrong with the child, there's been an injury or an accident, and how do they wind up coming to the advanced physical therapy locations?
Yeah, so most of the time it starts by them consulting with their healthcare practitioner, their doctor or pediatrician or whoever it is that is taking care of them. A majority of our patients are referred from physicians, so we have relationships with a bunch of local physicians that we work together with on helping their patients. The reason for that is state laws require us as physical therapists to treat patients under a prescription in order for the insurance to pay for the services. So that's kind of where that comes into play. But yeah, that's generally the starting point is from the doctor, and then the doctor will reach out or recommend therapy interventions.
So I just can't go down the street, knock on the door of advanced physical therapy and say, hey, I've got this problem with my arm, and come in. You have to get a referral.
Well, you can come in if you wanted to pay out of pocket for cash services. There are programs that we have for cash-based services. However, a majority of patients and people would prefer to use their insurance, and so that requires them to get a prescription.
So let's say a younger patient comes in, a referral from his or her doctor, and there's some diagnosis. How do you assess the patient, and what kind of plan would you put in place, say, for a kid who's got a problem with his or her arm?
Yeah, no, I mean, the first step in the process is the evaluation and assessment. So we usually go through a very thorough subjective history. We have a lot of conversation with the patient and or family members to get a history of what happened, what they were able to do prior to their injury and what they're not able to do now. So it starts with the subjective history. From there we move into more of an objective evaluation, looking at how does the joint move, what muscles are doing the work versus what muscles aren't doing the work, right? So
which ones should be doing it versus which ones aren't?
Exactly,
Okay.
and most of the time it works out to an imbalance in the system where certain muscles are just shut off and then certain muscles are overworking, and that can create problems, right? So that's where we get a lot of our plan of how we're going to help the patient.
So you're talking about muscles. What about, not breaks, but like there's tendons and those type of things? That's part of the musculature system, and the whole knee bone connected to the shoulder bone.
Right.
How do you assess something like that?
Yeah, so it really, that's where the kind of the professional assessment of knowing where the problem's coming from. If we can't identify where the problem's coming from, it makes the job of helping that person a little bit more difficult. Some people have multiple things going on at once, and some people are pretty straightforward, like a textbook, right? And so our ability to assess and then monitor how they respond to interventions, right? If we think something is occurring at a muscle and we're treating it as a strain and it doesn't seem to be responding as a strain, we might need to try something different or potentially refer back to the doctor to get more testing or things like that.
So if patients come in, you've done an assessment, and then you put a plan together. What's a typical plan, say, for like you said, with the sprain on the arm?
Yeah. So typical treatments in our clinic are generally about an hour in duration each session, and we see most patients anywhere from 2 to 3 times per week. I would say the average duration of someone in our clinic is anywhere from 10 to 13 visits-ish. And that allows us to really get the injury under control early on in the process, and then giving them tools to gain more strength, gain more motion, manage their pain or symptoms that they're having. And then at the end of the program, almost every patient we work with leaves with some sort of homework, right? So that we give them, the most important 4 or 5 things that are relevant to their scenario at that time. And then it's up to them to maintain that on their own, and that's the recommendation at discharge.
So that's the one prescription that you can give them we talked
Yes.
about before. So they've got, here's what you're, do patients who've come in 3 times a week, do they have to do, or do you recommend that in between the visits, what would you have them do to help themselves on a daily basis?
Yeah.
How important is that?
It's very important. It starts after the first visit. Every patient that I work with after day 1 has homework. It's not the same stuff they're going to be hopefully doing at the end of their care, but more basic things to just preserve the success of that treatment, right? If we see a patient twice a week, there's 5 days where we're not working with them, so it's really up to them to maintain what we've gained in the clinic and preserve that, so we're not just repeating the same process each time we work with them.
So when a patient comes into the clinic, what kind of hands-on, hands-off, what kind of physical equipment would you expect to see as a patient, and what would you be using as the treater?
So I'm a certified manual therapist, so I'm a big believer in what my hands can do to help a patient, either from a stretching of a muscle or mobilizing a joint or working on tissues from like a massage or soft tissue mobilization perspective. So most of the treatments in our clinic involve some sort of manual intervention from the therapist in conjunction with exercises. And exercises can range from stretching to strengthening to endurance activities to balance activities. There's a wide array of things we can provide, again, based on the needs of that individual.
So how much of it is hands-on stuff that you're doing, and how much of it is directing some activity either by themselves or with some equipment?
Yeah, so each session in our clinics, the individual gets 30 minutes of one-on-one time with the therapist. So that's our opportunity to use our hands to really direct them into what we want them to do that visit. And then the remaining time is spent doing supervised exercises.
The hands-on part, my wife is among her many talents and skills, she's a massage therapist, and very much she can, by the tactile information she gets back, she can say, yeah, you've got a problem here, but it starts over here.
Absolutely.
How important is that, learning how to do that as part of a physical therapy regime?
A lot of it goes back to the education and experience in working with patients, and I always use the phrase with my patients in the clinic that where you're having the pain often isn't the source of it. Pain is evil. It tends to present in different areas when the source of it might be coming from somewhere else. And our job as the professional is to find out where that source of the pain is and address that. But you're like you mentioned with your wife, feeling for where those restrictions are is key, and that allows us to hopefully help more people.
So you bring someone in. There's a half-hour session, a part of the 1-hour typical sort of session. What happens the rest of the time?
Yeah, so they're doing supervised exercises. Usually I'll be working with a patient on a table, and then I'm still in line of sight to be able to make sure they're doing things correctly. Oftentimes when patient can't raise their arm very well, they're going to try and compensate in some way that might not be appropriate. So we're looking for those types of things. So they're doing an exercise program, stretching programs, things that aren't required for me to be with them one-on-one.
One of the smaller parts of the body is the hand. And does anybody ever come in with a hand problem and say, will I be able to play the piano when I get done, Doc?
Yeah, so
it's funny, I couldn't play before, right?
Yeah. There you go. Yeah, so we see hand wrist problems. We see a lot of things that we see in the clinic regarding the hand are work-related injuries or like repetitive strain type injuries. I worked with a patient earlier this week, as a matter of fact, and she had a crush injury of her hand. It got pinned between a cart and a pole at work, and so we're working on her restoring motion and being able to grip and hold objects. Right now she's unable to even hold like something like a cup of coffee. So it can get to that level in the acute phases of healing. before long, she's hopefully going to be pushing a 50-pound cart at work again, right?
So we're going to move up from the small parts of the body to the bigger parts of the body. But first, we're going to take a break, get some words about Kiwanis. Don't go away. We'll come right back with Dr. Jeff Garbacz from Advanced Physical Therapy. Getting on to the good stuff now. Don't go away.
I am Kiwanis. I believe in people. I care about service. I seek out connection. I matter to my community because my community matters to me. I reach out to others. I reach inside myself because I am Kiwanis. I know a good cause when I see one. I know a kindred spirit when I meet one. I know the impact we make together when our need to help meets our willingness to act. I am Kiwanis. I take notice. I take pride. I take action. I take the opportunity to make a real difference in the life of a child, in the life of my town, in the part of myself that grows stronger by working and serving with others. I'm here. I'm inspired. I am Kiwanis.
Welcome back to KiwaniTalk. I'm your host, Gary Gardner, for this episode with Dr. Jeff Garbacz from Advanced Physical Therapy. Moving on to the good stuff. And during the break, you mentioned something about an anti-gravity treadmill.
Yeah.
So we'll get to that that's a tease for you people. We move on from the juveniles and teenagers. Let's go on to the middle-aged people and the older people like me. How does the level of presentation of cases come as they change as they get older? What happens to people, not just their arms and things, it's now, what's the biggest part you see?
Yeah, I would say, as individuals age in our clinics, and I'm assuming this is the same in our competition in any therapy clinic, around the country or world for that matter, is we see a lot of lower back problems, spinal problems, kind of more of the degenerative type of conditions. Osteoarthritis here in the United States is prevalent for many reasons, but we treat a lot of that kind of wear and tear stuff as people age, and we see that in our clinic all day, every day.
So that type of thing, is that preventable, or is it just natural, or is there something, exercise help it or prevent it? Or
Yeah, I mean, there are ways to prevent it. Being active is a huge plus. However, being too active can be detrimental, right?
That's why they come to see you when they're too overdoing it.
Yeah, it's a very fine line. And I can't tell you how many people I've worked with in my career that come in and they say, I was a runner or I was an athlete, and and then I look at them and their knees are shot from all of that activity. And unfortunately, that's one of the main reasons we have work, right, is to be able to help people like that. So it's a very fine line of being fit and maintaining your physical condition, but also dealing with the ramifications of being active. It's a tough thing.
So with backs, and back pain is amongst the worst, and I've been lucky not to have had too much of it. How much of it is trauma? How much of it is from just the osteoarthritis and the just aging part of it?
It's really, I would argue that probably every individual will have a back pain episode at one point or another in their life, right? Sometimes it's mechanical and how things are moving or not moving in the spine. Sometimes it's neurological, so patients who get like a sciatica type symptom where the pain goes down into the leg, like we said earlier, they'll have pain in their calf, but it could be coming from their lower back. And so those are things we see in the clinic all the time. And we have modes of treatment and ways to help people with stuff like that, but those are challenging, especially if there's other comorbidities, if the patient is overweight, or if there's diabetes involved, or hypertension, or if they smoke.
Stop looking at me. I got 3 of those.
Yeah, I know. But I mean, that's what we deal with, right? So
how would you treat a patient with you've got the imaging and the reports from the doctors, you've looked at them, you've assessed them. Is there a standard course of treatment, or is there a generalized sort of, here's a plan for everybody?
Yeah, I really try to avoid the cookbook recipe, right? Because I could have 10 patients with the same symptoms and presentation, and I would probably have to do something different for each one of them, based on their goals of what they want to achieve, and based on what I feel might be contributing to their problem. Somebody with pain in their leg, for instance, three different reasons off the top of my head that could contribute to that is an actual lower back problem. There could be a problem in the hip, and it could be just simply tightness of the calf, right? So we have to discern kind of what is contributing to that, and that's what goes back to what we said earlier with our assessment and really putting an appropriate plan in place.
And you've got equipment. It's not just medicine balls and dumbbells you have. What are some of the stuff that you have?
Yeah, so we have weight machines in the clinic. We have pulleys. We use stretchy bands for resistance. We have cardio equipment. So we have in the clinic in Dearborn, we have a treadmill. We have an elliptical. We have a few varieties of bikes. Some that have backrests, some that don't. We have a new step machine, which is like a recumbent stepper where the patients can move their arms and legs together, which is really nice. We have what we call an upper body ergometer. We call it the UBE, and it's basically a bike for your arms. So we use that a lot for like neck and upper back shoulder patients to get those muscles warmed up before we actually work on them.
What's the anti-gravity thing, though?
Yeah, the anti-gravity machine. So that is actually at our Southgate clinic, which is in Southgate, Michigan, and it is it's a very expensive treadmill, and it has this like cage around the treadmill that unweights the body. So if someone is recovering from a knee replacement or had a fracture of their ankle and the doctor only wants them in what they call partial weight bearing, we can put them on this treadmill, put them in this unweighting machine, and it allows them to walk and ambulate with less body weight and less gravity going through their joint. Very, very effective. Patients at that clinic, we have patients that come from long distances just for that piece of equipment because there's not a ton of them around, and our facility is one of those, so it's nice.
You just mentioned two locations, Dearborn and Southgate, but there's Advanced Physical Therapy has more than two locations. Tell us about the locations in the Detroit metro area.
Absolutely, yeah. So we have 8 locations in Metro Detroit. We range as far south. We have a clinic in Monroe. We have a clinic in Trenton. We have a clinic in Southgate, the Dearborn location, which is not far from here, and then east side in Grosse Pointe, Berkeley, West Bloomfield, and Rochester Hills.
So you're pretty much located wherever, all around the area.
Yeah, there's lots of locations that people could find us.
And again, if you have one specific need for equipment, you probably have a lot of it, but you can refer them to part of your network that you have around here.
Absolutely, yeah.
So you have people who come in, I imagine, on crutches or wheelchairs, or they walk in and they run out the door. Or how does that work? What for you, Dr. Jeff? What is the most gratifying sort of example that you have, the one that you feel the best about?
Yeah, we have 2 patients in the clinic right now that are in the caseload, and I'm not even working with them every single visit, who they came in a wheelchair, non-ambulatory. And now currently, we've been working with one of these patients for a number of months, and she is now walking in and out of the clinic with a walker, but she can ambulate, and she hadn't walked in years. Her goal was to be able to go to a restaurant with her family, and she came in about a month ago, and we celebrated with her because she was able to go in and out of Red Lobster with her family, and that was a goal that she had set a long time ago. And that's why you go to work every day. I mean, it just keeps you going to see the success stories and to make people feel better, and it's very rewarding. I mean, I have countless stories I could share regarding that.
Always feels good when you help someone and
Yes.
you can see the progress. I'm going to guess that person was there for more than 13 sessions, though.
Yes, she was, and she worked her butt off all of those sessions, and she continues to do that, and it's just nice to see the benefits.
That's a great point. How much of what you do depends on how cooperative and engaged your patients are?
Yeah, I mean, so much of what we do is training the muscle here, right? Getting the patient to believe they can do it, and because it's I'd like to say it's not magic, right? The recipe, we guide the patient, but it's a partnership between the patient and the therapist. And the environment of our clinic in Dearborn is motivating for people. They feel empowered by what they see other people doing and sharing stories with others, knowing that they're not alone. But I always tell people, when you come here, expect to work hard, and in a week or two, you will start reaping the benefits of that.
How many people are given the option from their doctor, if you know, surgery or physical therapy, and which do you think, I'm going to know what the answer is, but which do you believe is the best method?
Quite frankly, there are times where surgery is indicated, right? And there are patients that we work with that we see for a handful of visits, and unfortunately, we're not making the progress that I would expect, and we recommend them to go back to their doctor. So sometimes that is necessary. The one thing that we preach to our staff is that, if we are good clinicians, we should recognize when we can't help somebody, and making sure we get that person into someone's hands who can help them. If that's physical therapy, awesome, right? Well, that's what we're here to do. But if it's not, we need to recognize that and make the appropriate referral to who can help them. But yeah, it's a big part of it, is making those decisions and getting people to buy in and work hard.
So you've been doing this for about 20 years now. Ooh. Yeah, it's hard. Yeah, I've been practicing law, be 40 years in May, and that time went by fast. But when you started, the level of equipment and knowledge that you had has changed. Mm-hmm. It's today's level with the anti-gravity machine. What do you hear whispers coming down the pike? We got about a minute and a half to go.
Yeah, I think it's just gaining more knowledge. Like, there's fads that seem to go in cycles, right? And you see this in probably every profession. But years ago there was a certain approach to treating a back problem, and that kind of came and went. And then through research and knowledge, we gained more information, and we kind of shifted to a different approach. So as we learn and constantly educating ourselves and getting the research to support, yes, this is the right thing, or no, this isn't, it's a constant evolution. They call it practicing medicine for a reason, right? We're always learning and trying to make educated decisions so we can maximize the outcome.
We're practicing so we can get better.
Absolutely.
And help your patients, my clients, help them get better.
Absolutely.
Well, it's been a real pleasure having you here, Doc. I've learned a lot, and,
awesome.
And not that I ever want to have to come see you.
Right.
But if I got recommended, tell your people, don't be afraid to go to physical therapy.
Absolutely.
It sounds intimidating, but sounds like advanced physical therapy has the right kind of people, the director of operations in charge of it. And what's the phone number real quick?
Yeah, Dearborn Clinic, 313-565-4222, and we're located in Dearborn on Michigan Avenue, between Telegraph and Outer Drive.
And plus 7 more all over Metro Detroit.
7 more all over Metro Detroit. Come see us if you need help.
Thank you very much, Doc. Nice to see you.
Thank you.
Thank you for coming to KiwaniTalk. I'm Gary Gardner. See you next time. And if you need physiotherapy, go get advanced physical therapy. Bye-bye.